The CORALREEF heterozygous familial hypercholesterolemia trial, a double-blind randomized controlled trial of enlicitide decanoate, an oral PCSK9 inhibitor in participants with heterozygous HeFH. In patients with heterozygous HeFH, elevated LDL levels from birth can lead to premature atherosclerotic cardiovascular disease. It has been a challenge to achieve LDL goals despite currently available therapies. As you know, PCSK9 regulates LDL levels. Injectable anti-PCSK9 antibodies offer powerful reduction of LDL and cardiovascular outcome benefit, but has been underutilized. Enlicitide decanoate is an oral PCSK9 inhibitor, which works similar to the monoclonal antibodies by binding to PCSK9 and preventing its interaction with the LDL receptor, leading to upregulation of LDL receptors and improved clearance of LDL cholesterol from the bloodstream. In spite of a number of effective therapies to lower LDL, far too many patients failed to achieve guideline-recommended targets. Although injectable PCSK9 inhibitors offer powerful LDL reductions and cardiovascular outcome benefit, they are underutilized. In phase 2 studies, enlicitide lowered LDL cholesterol by up to 60%. The CORALREEF heterozygous FH trial was designed to study the safety and efficacy of enlicitide over 52 weeks. 303 subjects were randomized in a 2-to-1 ratio to 20 milligrams of enlicitide or placebo and followed for 52 weeks, with either an 8-week safety follow-up or continuation of an open-label extension. Inclusion included participants with heterozygous FH with a history of a major ASCVD event and LDL greater than 1.4, or without a history of a major cardiovascular event and a higher LDL greater than 1.8. The key exclusion criteria listed here including patients with homozygous FH or a recent event. All patients had to be optimized and on stable background lipid-lowering therapy with at least moderate or high-intensity statin. The mean age was 53 years, about 50% were women. You can see the global participation with a highly ethnic and racially diverse population. 31% of participants were Asian, 11% were Black, 21% were Hispanic. 54% of participants had a history of a major ASCVD event. The remainder were enrolled because they were at high risk for cardiovascular disease. At baseline, 99% of patients were on a moderate or high-intensity statin. Use of cholesterol absorption inhibitors like ezetimibe was 66% overall. The mean LDL was 120, which is about 3.1 millimoles per liter. Here are the results of the primary endpoint. There was an 8.7% increase in LDL in the placebo group and a 55% decrease in the enlicitide group at 52 weeks. The placebo-adjusted between-group difference was 61.5% at week 24. Here you can see on the right of the panel that all the parameters have improved, with a 53% reduction of non-HDL, 49% reduction of ApoB, and 27.5% reduction of Lp(a). In terms of achieving guideline-based goals, when adding enlicitide to background statin therapy, in those receiving enlicitide, 71% of participants achieved LDL goal less than 1.8, and 67% achieved the goal of less than 1.4, a significant difference compared to placebo. Enlicitide was very safe and well tolerated with very low discontinuation rates. There were no signals compared to placebo. There was high adherence to the fasting and dosing instructions. It required individuals to take the drug after an overnight fast, first thing in the morning, and abstain from drinking anything for 30 minutes period. 97% of patients were able to adhere to that instruction. So in a global diverse population of participants with or at high risk of vascular disease, once daily enlicitide demonstrated PCSK9 monoclonal antibody-like efficacy at 24 weeks. Robust reductions in LDL cholesterol and other atherogenic lipid proteins were maintained through 52 weeks periods. Enlicitide was safe and well tolerated and reported a high participant adherence rate.